is B1 with lymph nodes, C2 is B2 with lymph nodes, D is your distant metastasis. This is your distant metastasis, right? Now, TNM classifications are there. The minimum number of lymph nodes to be removed in order to stage is going to be 12. Now, based upon the location, if there is a cecal malignancy or an ascending colon, it is going to be cecal or ascending colon, then you have to go with left radical hemicolectomy. If the lesion is on the hepatic flexure or on the transverse colon, then you have to go ahead with, sorry, this is right radical hemicolectomy. This is the right side, this is the left side. This is your right radical hemicolectomy. If it is on the hepatic flexure, HF is your hepatic flexure, TC is your transverse colon, then here you have to go ahead and extended right radical hemicolectomy. It is your extended right radical hemicolectomy. If it is on the splenic flexure, then it is your extended left radical hemicolectomy. It is your extended left radical hemicolectomy. If it is on the descending colon, then it is your left radical hemicolectomy. If it is on the sigmoid colon, then it is your sigmoid resection. That is going to be your sigmoid resection. Okay. So these are with respect to various sites and the type of surgeries that you're going to do. I've given you the resective criteria. Go through it if you have time, otherwise not important, right? Now, in terms of rectal prolapse, remember the criteria. For a partial, if the length of the prolapsing segment is less than 4 centimeters, for complete it is more than 4 centimeters. That is the only criteria to remember. The cause here, it is going to be acute attack of diarrhea. Acute attack of diarrhea. Acute attack of cough. It is going to be acute attack of diarrhea or the acute attack of cough, right? And straining during defecation. It is straining during defecation, right? Whereas with respect to your full thickness rectal prolapse, it is seen secondary to an obstructed labor. Secondary to an obstructed labor, or it can be seen secondary to a chronic constipation. To a chronic constipation. Clinical feature, you can see a prolapse segment. Investigation is going to be a clinical examination. Remember, for a partial thickness prolapse, if it is a child, you can go with digital repositioning. It is going to be digital repositioning can be performed. If not for adult, I will not do a digital repositioning. I will perform sclerotherapy. If that fails, then you have to go with surgery. Usually it responds with Thierch wiring. For a full thickness prolapse, you have to go with surgery. You have two routes. One is your perineal approach. Another one is abdominal approach. One is perineal, another one is the abdominal approach. Now, in a perineal approach, you have Thierch wiring. You have Thierch wiring. You have Delrum's procedure, as well as Altemus. For an abdominal approach, you have to go with Repstein. We have the Repstein surgery, Wells surgery, Lahout surgery. Another one is the Freichmann-Goldberg. It is the Freichmann-Goldberg surgery. It is the Freichmann-Goldberg surgery. Okay. So you have the Repstein's, Wells, Lahoud, Fragment, Goldberger's abdominal, Theoj, Delrom, and Altimeus is going to be the perineal route of approach. Simple, clear. Now we'll talk about the hemorrhoids. What is a primary hemorrhoid? What is secondary hemorrhoid? If the hemorrhoid is arising from 3, 7, or 11 o'clock, it is primary. If it is arising anywhere else, then 3, 7, or 11, it is considered to be as secondary hemorrhoids. Internal hemorrhoids are those hemorrhoids which are present above the dentate line. If they're present above the dentate line, it is internal hemorrhoids. If it is present below the level of dentate line, this will be called as the external hemorrhoids. This will be termed as your external hemorrhoids, right? Now, grades are on the basis of 2 criteria. One is bleeding, another is protrusion. In grade 1, there is bleeding, but no protrusion. Grade 2, the bleeding is present, protrusion is also there, but it is spontaneously reduces. It spontaneously reduces without any intervention. Grade 3, bleeding is slightly more. Protrusion is present, but this is manually reducible. It is manually reducible. Grade 4, the bleeding is present. The protrusion is present, but this time it is prolapsed. It is going to be collapsed, right? So this is with respect to the hemorrhoidal status that is going to be present. How do you manage, right? So management of hemorrhoids is pretty simple. You see whether it is thrombosed or non-thrombosed. Is it internal or external? So external hemorrhoids are categorized into 2 categories, thrombosed, non-thrombosed. If patient presents within 72 hours, you would go ahead with excision. After 72 hours, you will go with conservative management. In a non-thrombosed hemorrhoids, we will start with dietary modification. We'll try dietary modification. If this fails, then excision. For grade 1, it is going to be conservative. Grade 2, I would like to try banding or sclerotherapy. Grade 3, we'll try banding. If not, then excision. Grade 4, we will prefer excision. Now, excision of hemorrhoids can be of 2 types. One is the open surgical techniques, or I can say one is going to be surgical component, another one is using a circular stapler. This is a circular stapler hemorrhoidopexy. Surgery, you have open technique and closed technique. Open and closed. The open is what we call it as the Milligan-Morgan surgery. It is the Milligan-Morgan surgery. Closed technique is what we call it as the Ferguson's surgery. The closed technique is what we call it as the Ferguson's surgery. Okay. So this is with respect to the hemorrhoidal status. Clear? So when you talk about the perianal fistula, you have 2 components, the primary cause and the secondary cause. The primary cause is because of spontaneous rupture. It is because of spontaneous rupture of perianal abscess. Of the perianal abscess, that is the first one. The second is inadequate, or I can say incomplete drainage of perianal abscess. There is an incomplete drainage of perianal abscess. Incomplete drainage of perianal abscess, right? When you talk about the secondary cause, it can be seen secondary to Crohn's disease. It can be seen secondary to TB of anal canal. It can be seen secondary to radiation proctitis. right? So Crohn's disease, TB, and radiation are the three causes of secondary component. Now, in order to understand the perianal fistulas, we have a Parkes classification. Remember, the most common type is the intersphincteric variety. The others are trans, supra, and extra sphincteric variety, right? There's a Goodsall rule which tells you how do you orient the tract if the opening is in the anterior half. If the opening is in the anterior half of the perianal region, the tract is going to be straight. The tract is going to be straight, but if the opening is on the posterior half, then you are going to have a curved tract. Then you're going to have a curved tract, and this is what your Goodsall rules basically tells you. A perianal fistula is going to have a cutaneous ulceration. There is cutaneous ulceration in perianal region. Along with that, it will have a foul smelling discharge. It will have a foul smelling discharge. But the most important pickup point, there is fecal soiling of undergarments. There is fecal soiling of undergarments. There is a fecal soiling of the undergarments. Okay. Investigation of choice for the fistula, it is going to be your MR fistulogram. But if I say which is the best one, it is your endoanal ultrasound. Management is going to be fistulotomy. That is maximum that you should know. Right, so let's start with the rapid fire round. Are you ready? So the entire GIT is going to be listed in your 5 lists that I'm going to give. This is what you are going to revise before one day of your exam, right? So let's go with rapid fire. We'll start. So you have the list number 1. In the list number 1, there are disorders on one end. You have to either tell the most common type or the most common site. The first one is tracheoesophageal fistula. The most common type is your type C variety. Achalasia cardia, the most common site is going to be lower 1/3 of the esophagus. Zenker's diverticulum, it is seen on the cervical esophagus, and that too on the posterior surface, and that too on the left side, right? Now, esophageal carcinoma, it is seen in the middle 1/3. Barrett's is seen in the lower 1/3. Plummer-Vinson syndrome is seen in the upper esophagus. It is the upper esophageal web that you have. Boraf syndrome will be in the lower 1/3 of the esophagus. Mallory-Weiss-Stare, the most common site is going to be cardia of the stomach. Peptic ulcer disease is first part of the duodenum. Gastric ulcer is seen at angularis incisura. It is seen at the angularis incisura. Interception, if you're talking about children, then it is going to be ileocolic. But if I say adult, adult is going to be colocolic. It is going to be colocolic. Are you keeping up? Are you keeping up? Fast ho gaya? चलो कंटिन्यू. Volvulus का most common site क्या है? It is going to be sigmoid colon. It is going to be sigmoid colon. Diverticulosis का most common site is also sigmoid colon. Polyps का most common site is going to be rectum. TB stricture is going to be terminal ileum. Typhoid perforation is terminal ileum. Ulcerative colitis का most common site is rectum. Crohn's is going to be terminal ileum. Hirschsprung disease, most common site is going to be rectum. Ischemic colitis is going to be most commonly seen on splenic flexure. Superior mesenteric artery syndrome will cause D3 obstruction, which is the most common site. Acute mesenteric ischemia, it is the middle colic artery, which is the most commonly occluded artery. Large intestinal malignancy, it is most commonly seen on rectosigmoid. It is seen on the rectosigmoid. Perforation in peptic ulcer disease. Remember, it is the duodenal ulcer that perforates, and it is the gastric ulcer that is going to bleed. The most common source of bleeding in peptic ulcer disease is your gastroduodenal artery. It is your gastroduodenal artery. The fistula, I know what is the most common type. It is your intersphincteric type. It is the intersphincteric type. Hemorrhoids, most common is your internal hemorrhoids. It is your internal primary hemorrhoids. Anal cancer, it is most commonly below dentate line. So that finishes your list number 1. Okay. But everything that can possibly ask, we have finished under 1 minute. That is the goal for you to understand and revise with me as well. Okay. So list number 1 is done. Going to list number 2, we have the named ulcers. Unka location bata do. Aphthous ulcer kahan dekhoge? They are seen in the Crohn's disease, and usually seen, the aphthous ulcer are usually seen in the oral cavity. Cameron's ulcer is seen in rolling hiatal hernia. It is seen in the rolling hiatal hernia, and that too in the fundus of the stomach. It is the fundus of the stomach. The peptic ulcer disease, first part of the duodenum. Gastric ulcer is seen at angularis incissura. It is seen at the angularis incissura. Duodenal ulcer is the first part of the duodenum. TB ulcer is going to be terminal ileum. Typhoid ulcer is also seen on the terminal ileum. Bell-shaped ulcer is nothing but because of TB. It is also seen in terminal ileum. Flash-shaped ulcer is seen in amoebic colitis. It is seen in amoebic colitis. It is most commonly seen on cecum, if not then on the ascending colon. Serpentine ulcer, it is seen in necrotizing enterocolitis, and this is seen in usually in the ascending colon. Cobblestone mucosa, it is seen in Crohn's disease, and the most common site is again going to be terminal ileum. Solitary rectal ulcer is seen in rectal prolapse. And the skin lesions are also seen in Crohn's disease. It is going to be a Crohn's disease, right? So these are the sites and the status that you'll see. Crohn's disease overall most common site is going to be terminal ileum. This concludes your list number 2, the named ulcers and its sites. Do not forget it. Now, list number 3, your GI malignancies and the chemo regimes that are important. For esophageal cancer, it is ECF. That is going to be epirubicin. Your cisplatin, and your 5-fluorouracil. For stomach cancer also, it is ECF. Small intestinal adenocarcinoma, it is going to be FOLFOX. Large intestinal carcinoma is also FOLFOX. Rectal cancer is also going to be FOLFOX, or you have FOLFOVIRI, right? FOLFOX or FOLFOVIRI are the regimes that you can use. So I hope everybody knows the component of FOLFOX and FOLFOVIRI. In FOLFOX, FOL stands for folinic acid. It stands for folinic acid. Another F stands for 5-fluorouracil. OX stands for oxaliplatin. And on the other hand, IRI stands for irinotecan. It stands for irinotecan. Okay. Chalo. Anal carcinoma, it is going to be Negros regime. It is going to be Negros regime. And the Negros regime is going to be 5-fluorouracil with metamycin C. With metamycin C with radiotherapy. Okay. Gastrointestinal stromal tumor, it is going to be, we say, imatinib. If it is resistant to imatinib, then it is sunitinib. It's going to be sunitinib. HCC, it is going to be, so for hepatocellular cancer, the drug that you can give is sorafenib. For gallbladder cancer, it is going to be gemcitabine. It is gemcitabine with cisplatin. The same can be given for your cholangiocarcinoma. If your pancreatic ductal adenocarcinoma, it is gemcitabine alone. So these are the chemo regimes. So this is your list number 3. List number 4 is your proximal and distal margins. For esophageal cancer, the proximal margin of resection is 10 centimeters. Distal is 5. Rest everywhere, the proximal and the distal margin. The proximal and the distal margin will remain at 5 centimeters. Whereas in rectum, again, proximal is 5, distal is going to be 2 centimeters. So we have 2 areas of skewed data. One is going to be proximal esophageal margin. Another one is going to be your distal rectal margin. It is going to be your distal rectal margin, right? So this is about your list number 4. List number 5. What is the management surgery names you have to tell me? Okay. Now, for achalasia cardia, it is going to be your Heller's cardiomyotomy. It is your Heller's cardiomyotomy. For diffuse esophageal cancer, it is your long esophageal myotomy. So we are talking about the surgical management here. Zenker's diverticulum, you have the Dolman's surgery. Esophageal cancer, remember 3 surgeries. We have Ivor Lewis. We have the McKeown. And we have the Oringers. CHPS is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. For perforated peptic ulcer disease, it is your Graham's omental patching. It is your Graham's omental patching. For peptic ulcer disease, it is, you have to go with triple or quadruple therapy. For GRD surgical management, the surgery of choice is going to be Nissen's fundoplication. For D1 stricture, you have to go stricturoplasty. The name is Heineken-Mucklitz. It is the Heineken-Mucklitz pyloroplasty. For duodenal atresia, it is duodenostomy. For jejunal atresia, it is jejunostomy. It is going to be jejunostomy. For ulcerative colitis, it is going to be total proctal colectomy. It is a total proctal colectomy with ileoanal J pouch anastomosis. With ileoanal J pouch anastomosis. For diverticulosis, it is elective sigmoid resection. It is the elective sigmoid resection. For FAP, it is the same. Total proctal colectomy with ileoanal J pouch anastomosis. For rectal prolapse, you have the surgeries that are decided. We have written the perineal rouge. It is going to be Thierge wiring. If not, then you have to go ahead with Repstein surgery. So remember these 2 surgery names more than enough. Thierge is going to be perineal root. Thierge is perineal root. Repstein is abdominal root. Hirschsprung disease, you have to do a pull-through surgery. Now, in a pull-through surgery, you have Duhamel's, Swenson, and Soas. For hemorrhoids, you have 2 surgeries that you have to remember. Number 1 is Milligan-Morgan. And Ferguson's surgery. For adenocarcinoma of the anal canal, you have to go ahead with APR, that is abdominoperineal resection. It is going to be your abdominoperineal resection. Right? So this concludes your entire GIT. एक बार quickly देख लेना, your things would be sorted. Okay? So all these tables are for your quick recap of your entire GIT. Exam से एक दिन पहले अगर time रहा तो tables देख लेना, which is more than enough. ठीक है? Nothing more is important. Clear? चलो. Let's continue. We're talking about liver. अच्छा, before that, just give me a couple of seconds. पानी खत्म हो गया. I need to get some water. There's nobody around. 1 second. Just hold on for a second, guys. I'll resume it. ओके, भूल तो नहीं यार, भूले नहीं है यार, आई एम ट्राइंग टू अरेंज क्योंकि इट्स ऑलरेडी 8:30, सो आई वाज ट्राइंग टू सी दैट हाउ लॉन्ग कैन आई टेक द क्लास. या आई नो इट्स बीन हेक्टिक, विल ट्राई टू फिनिश लिवर. ठीक है, प्यार से पढ़ाऊंगा, टेंशन नहीं लेना. लिवर खत्म करते हैं, विल ट्राई टू सी व्हाट बेस्ट वी कैन डू. ठीक है. ठीक है, चल. So there are certain terminologies in liver resection. Acha, can anyone tell me when you're talking about right hepatectomy, what are the segments we are going to remove? Segment 5, 6, 7, and 8. For left hepatectomy, I'll be removing segment 2, segment 3, segment 4A, segment 4B. Right anterior sectionectomy will be 5 and 8. Right posterior will be 6 and 7. Left lateral is going 2 and 3. Left medial is 4A, 4B. Right trisectionectomy from the right side, 3 sections. Yeah, I'll talk to Sudha ma'am also. एक second, अभी बात कर लेते हैं. एक second रुको. Sudha ma'am is only taking, no? FTR कौन ले रहा है? Ofta का? Ofta का FTR कौन ले रहा है? Sudha ma'am, अच्छा, एक second. Yeah, let me confirm with ma'am once. Hello. Hi ma'am, good evening. Ma'am, absolutely fine, ma'am. I'm sorry to disturb you right now. Okay. Ma'am, tomorrow you have this FTR, no? अपना राइज में कब तक खत्म हो जाएगा आपका? बिकॉज मेरा सर्जरी का थोड़ा पेंडिंग है. आई वाज थिंकिंग इफ यूर. अच्छा, 7:30 विल बी डन. ठीक है, कैन आई schedule it from 8 o'clock onwards? ओके, सो आई विल टेक फ्रॉम 8 onwards एकदम. मेरे को 2 घंटा ही लगेगा, यूरोलॉजी बचा हुआ है, तो आई फिनिश इट ऑफ. ओके. हम्म. Yeah, I also did TNT, लेकिन मटेरियल थोड़ा एक्सटेंसिव दे दिया इस बार. तो आई टेक टुमारो 2 hours, आई टेक ऑफ एंड फिनिश. Right. So tomorrow we have class after off that. Don't worry. I spoke to ma'am. So it's all sorted. Relax रहने का. Chill. Yeah, बेटा, I want to start. लेकिन अगर मैम कुछ बोल रही है, कॉल किया है तो सुनना तो पड़ेगा ना यार. ऐसे थोड़ा फोन रख देंगे. चलो. So right tricectomy from the right side you have to remove 3 sections. So right side में कौन-कौन से हैं? 5, 6, 7, 8 section. Along with that, immediately next to it is going to be 4A, 4B. So right side में 3. लेफ्ट साइड जब निकालोगे 2, 3, 4A, 4B निकालोगे, इसके साथ सेगमेंट 5 and 8. Those बच्चास who are not able to understand or remember, ये हमारा लिवर का सेगमेंट है. And this is how the liver is going to look in a 3D extension. So when you talk about its division, we know there is a Cantel's line that is going right in the center, which is going to be dividing the liver into the right and the left hemiliver. Then you see there is another one, which is your hepatic vein, which is dividing the right side of the liver into anterior and the posterior section. Whereas here there is this hepatic vein, which is dividing the liver into medial and the lateral section. Then you have the hepatic vein that is going to, the portal vein that is going to run. The portal vein is going to run in this fashion, that is in a transverse manner. It is going to divide the entire liver into transverse halves. Okay? So this is the entire division of the liver that you have. Now, if you observe very carefully, I'll just quickly shadow it off. This is segment 2. This is segment 3. This happens to be segment 4A, which is going to be here. This is going to be segment 4B that is present, right? So this is your segment 2 that is present. Now the anterior segment that you see, this is your anterior segment. I'll use a different color. This is the anterior segment, which you are seeing across here. Right behind this, you have a posterior segment, which is here. Another posterior segment that you have is this area, which has been marked across here. And then one more area that you have is going to be this. So you see all these shaded areas is each individual segment that you have. If I label it, this is going to be your segment 2. This is segment 3. This is 4A. This is 4B. This entire is 5. This is 6. This is 7. And this happens to be 8. Okay. Now you can see very clearly that is lateral medial section, anterior and posterior section as well. Clear? Clear? Liver sections are easy. Okay. Okay. So in liver infections, 3 important infections that we're talking about, that is pyogenic, amoebic, and hydrated cyst. The causative agent for this is going to be bacteria. The other 2 are going to be parasites. The other 2 are going to be parasites. So when you talk about it, the most common organism causing here is going to be E. coli and Klebsiella. E. coli and Klebsiella. Amoebic liver abscess is going to be Entamoeba histolytica. Hydrated cyst is Echinococcus granulosus. It is going to be Echinococcus granulosus. But I cannot take in the morning because if most of you know, I'm a practicing surgeon also. So morning is for my patients or evening is for my students. So distinction clear rakhenge. That is why I was not able to take the lecture in the morning today also. So I had to start at 12:30 only. I had a case finished and then start. ठीक है? नहीं बेटा, आप भी बहुत important हो. ऐसा कुछ नहीं है कि मैं अपने convenience पे लूँगा. I'll try to cater for both the ends. See, I've worked hard all my life to be a surgeon, so I cannot compromise that also. At the same time, I love teaching. I'll not compromise that also. Okay? So, koi tension nahi. What is the route of spread? How does it get down in terms of pyogenic liver abscess? It is the bile duct, which is the most common route of spread. If this is not in the option, then you have portal vein. If not, hepatic artery. If not, direct route of spread. Amoebic liver abscess, it comes to the body as amoebic colitis, causes a flash-shaped ulcer in the cecum and via the portal circulation. Via the portal circulation, it is going to reach down to the liver. Hydrated cyst, that is your Echinococcus granulosus. That Echinococcus granulosus enters because of improperly cooked meat infested with Echinococcus granulosus, which the patient eats, and via the portal circulation in the body. Via the portal circulation in the body, hydrated cyst is going to reach to the liver. Kalka class beta, after the ophthal class is done, we'll give you a half an hour break and we'll resume. तो मैम इज सेइंग कि 7 बजे तक हो जाएगा. अगर 7 बजे हो जाएगा 7:30 बजे शुरू करेंगे. अगर 7:30 बजे हुआ तो 8 बजे शुरू करेंगे. टेंशन नहीं लेना. Right now, when you talk about the age of presentation, now pyogenic liver abscess is seen in age above 50 years. It is seen between 20 to 30 years. Hydrated cyst is seen between 40 to 50 years. Now, remember pyogenic liver abscess, most commonly these are associated with males. Amoebic is also more common with males, whereas hydrated cyst is equally seen in both males as well as females. All the infective disorders are more common on the right hemiliver or the right side of the liver. Bacterial, whenever there is bacteria, it will disseminate more. So it will have multiple lesion. The other will have only solitary lesion. The others are going to have solitary lesion. Bacteria can never be endemic. Parasites can be endemic. Remember, in your pyogenic liver abscess, as the liver is getting infected, so there will be rubercular tumor. So patient is going to have right hypochondriac pain. There is right hypochondriac tenderness associated with high-grade fever. Will be associated with high-grade fever, and more importantly, because why it goes by bile duct, it will only happen when the bile duct is obstructed. There is possibility of obstructive jaundice as well. Now, amoebic liver abscess will also have pain, tenderness, fever, but here there will be history of colitis. As we all know, hydrated cyst, the growth is 1 millimeter per year, so mostly it is asymptomatic. Mostly it is asymptomatic. Even if it is symptomatic, it will only have palpable liver mass. It is palpable liver with fluid thrill, which is called as the hydrated thrill. This is called as the hydrated thrill is going to be present. The first investigation remains as ultrasound. We have already marked it across here. For all, it is ultrasound. Remember, the classification for hydrated cyst on ultrasound is called as the Gerbe's classification. The investigation of choice is going to be CCT for all three. For confirmation, aspiration and culture for bacteria, other two is going to be ELISA. How do you manage it? Remember, the management for pyogenic liver abscess, it is going to be USG guided aspiration. It is USG guided aspiration with antibiotics, right? Whereas your amoebic liver abscess, I will start the patient on high dose metronidazole. It is your high dose metronidazole, which is between 700 to 1000 milligrams per day. Okay. If it fails, then aspirate. And on aspirate, you see a very characteristic presentation. That is what we call it as the anchovy sauce appearance, which is chocolate brown in color. For hydrated cyst, I will do pair therapy. Pair is your puncture aspiration. It is puncture aspiration of the hydrated fluid, instillation of scolicidal agent. And re-aspiration. Instillation of the scolicidal agent and re-aspiration. Beta, all the triads in surgery, आपको लगता है मैंने नहीं दिया है? Important triads और GIT already है. आपके बोलने से पहले मुझे पता है आपके लिए क्या इंपॉर्टेंट है, तो थोड़ा ट्रस्ट रखो. ठीक है. Now, if they ask you what is the scolicidal agent that is there, number one is hypertonic saline. 10% povidone, 0.5% centrimide, 0.05% chlorhexidine. So hypertonic saline, 10% povidone, 0.5% centrimide, and 0.05% chlorhexidine are the scolicidal agents that you're going to use. Okay. Now, when you talk about the hydrated cyst, the outer layer is what we call it as pericyst derived from liver. Then the green layer that you have is the ectocyst, and the innermost layer, the blue one, is what we call it as endocyst. The endocyst is the germinal layer. And pericyst, it is derived from the liver's tissue. Okay. So these are with respect to infective lesions of liver, very, very important. Now, benign lesions of the liver are also important. Now, remember when you talk about hemangioma of the liver, this is the most common benign liver lesion. When you talk about pathogenesis, it is not a true tumor, it is a vascular malformation. It is a vascular malformation. Focal nodal hyperplasia, it is a hyperplasia in response to vascular malformation. It is in response to vascular malformation. Hepatic adenoma is a true benign tumor. It is a true benign tumor. And remember, the gene responsible is going to be HNF1 alpha gene mutation. It is a HNF1 alpha gene mutation. There are no specific risk factor. For hepatic adenoma, it is OCP as well as glycogen storage disease. The glycogen storage disease, it is usually seen in type 1 and type 3. Third one is your non-alcoholic fatty liver disease, that is steatohepatitis, right? So non-alcoholic fatty liver disease, this is not pre-malignant, this is not. If the size is more than 5 centimeters, it is considered to be pre-malignant. All three of them, they are usually asymptomatic. So this is also asymptomatic. So all of them are either an incidental finding or they are seen secondary to some sort of complication. They're seen secondary to some sort of complication which are present. So when the hemangioma ruptures, it can present to you with hemoperitoneum. It is your hemoperitoneum. Here there is no complication. Now hepatic adenoma is also vascular, so it can present to you with hemoperitoneum. Along with hemoperitoneum, it can also result in mass effect. That means causing compression of the surrounding tissues, causing biliary compression can result in your, it can result in obstructive jaundice. For investigation of choice for all three of them is going to be your triple phase CT. Management less than 5 centimeters of hemangioma. It is observation. More than 5 centimeters, it is enucleation. It is enucleation. Here it is do nothing. Here less than 5 centimeters, you have to go with observation. Here you have to go with observation. More than 5 centimeters, we have to plan for excision. We have to plan for excision. Remember, on a CT, here you will see central stellate calcification. Presence of central stellate calcification is noticed, right? So this is about all your benign liver lesions which are present. Now, usually they'll ask you the difference between the HCC and the fibrolamellar variant. In HCC, males are more commonly affected than females. Fibrolamellar variant are equally affected. The usual age of presentation is 55 years. Here it is 25 years. Tumor here, it is invasive, whereas fibrolamina variant, it is well circumscribed. That means it is well confined. Only 25% of HCCs are resectable. Fibrolamina variant, 75% of them are resectable. It is associated with liver cirrhosis. Fibrolamina variant is not. AFP is elevated. AFP is normal. Here you have to remember neurotensin, which is a tumor marker, which is elevated. It is normal HCC, or the HCC is associated with hepatitis B. Fibrolamina variant is not associated with hepatitis B. The prognosis is poor here. The prognosis is good in fibrolamina variant, right? So this is the comparison that you should know between the HCC and the fibrolamina variant. Okay. So let's stop here, right? You all can go eat something, rest, and start revising the entire material that we have done today. Tomorrow, we will resume back at around 7:30. And from there onwards, we have already finished 100 pages. Okay? Tomorrow, we are only left out with a couple of more pages and we'll be done. PDF, I am uploading right now in front of you. Export all. I will export. I will put it on the Telegram group and then only I'll move from here. अभी जाके खाना खाना, थोड़ा रेस्ट करना, उसके बाद पढ़ना शुरू करना. हाँ, tomorrow I'll start with the same PDF. Don't worry. My voice is also gone. Hopefully tomorrow it will get better. Beta, no, thank you. It's my job. And if I've done well, then that's pretty much about it. Okay? So, tomorrow's class timing, oftal khatam hote, you will see my shakal. Don't worry. Guys, if you want to do an additional revision, no, there is a small YouTube session that I did yesterday. It is top 10 topics. That's for NEET PG. But again, quickly rapid revision के लिए ना 1 घंटे का वीडियो है, फटाफट देख लो. ठीक है? So that will also help. You don't need to worry about people complaining. I never do. So I've taken the PDF. I'm writing RR day 1 and it is uploading. Okay. Question with PDF questions from us, like in many other subjects, they promised to give annotated PDF. But I've been used to giving PDFs. Don't worry. Okay. मैं क्या करूँगा इस PDF का? Every session I take, I keep writing it, I keep changing it, I keep evolving it. So it's always good and benefit for you. So we can score 60-70% question in the exam from this material. What is your opinion? I will tell you, my opinion is you will get 100% questions of surgery from this material. It is a promise. Okay? So don't worry about it. Beta, I am telling you, I'll repeat again. Ye material is more than enough. 100 out of 100 questions of surgery will come from this material. ठीक है, जो TND कराया है, जो आपका फास्ट ट्रैक रिवीजन हो गया बेटा अपलोड. ठीक है, कॉन्फर्मेशन भी दे देते हैं टेलीग्राम ग्रुप में. इट इज देयर. आ गया. क्या RR day 1 is uploaded. ठीक है, you can go to the Telegram channel. You have all the links which are required there. You can chill and leave across that. Right? बेटा, now it is the time only to look at your revision material. Notes पे अभी ध्यान नहीं देना है. Revision material, GTs and your previous year questions. That's it. बेटा टीएनडी के साथ एक बार देख लो, आई वुड रेकमेंड यू टू स्टिक टू दिस मटेरियल एंड टीएनडी, ये दोनों आपका कंप्लीट सोर्स है, ठीक है, डू नॉट नीड टू गो बियॉन्ड दिस पॉइंट। क्या बेटा सर्जरी के लिए ना, आई एम टेलिंग यू, यू विल हैव अ वेरी गुड टाइम। रिमेंबर, अगर आज का सेशन शिद्दत से सुना है, एग्जाम में एवरी सिंगल वर्ड दैट आई एम टेलिंग यू विल एको इन योर ईयर, आपको सुनाई देगा। आप एग्जाम में अच्छा करोगे, सर्जरी नहीं पूरा एग्जाम अच्छा करोगे, सो कोई टेंशन लेने की जरूरत नहीं है, ठीक है। आज का आज खत्म करो, सो जाओ, कल सुबह ऑफ्थाल करो, शाम को वापस सर्जरी पे करते हैं, विल फिनिश ऑफ, ठीक है। चलो, take care guys, good night, nice interacting with you, all the best for the exam, stay focused, huh? Chalo, bye. Chalo guys, take care, all the best, all the best, chalo, bye. Chalo guys, bye bye.